Good morning, everyone. Let me present my progress report on preconceptional, gestational, and postpartum carbohydrate metabolic disorders. My name is Dorina Greff. I'm a resident doctor at the Department of Obstetrics and Gynecology. My supervisors are Szabolcs Várbíró and Eszter Horváth. My vision to increase fertility and complication-free pregnancy rate, and my mission to achieve my vision by novel prevention strategies and to improve carbohydrate metabolism. Currently, I'm working on 3 projects about new therapeutic possibilities in polycystic ovary syndrome and gestational diabetes mellitus. In the first meta-analysis, we investigated the safety and efficacy of Inositol and metformin administration in the treatment of polycystic ovary syndrome. Currently, we are working on to finish the article draft with my supervisors. Polycystic ovary syndrome is one of the leading causes of infertility. The prevalence of it is 5 to 20%. The main characteristics of the disorder are polycystic ovaries on ultrasound examination, hyperandrogenism, and ovulatory dysfunction. Up to 60% of women with Pcos are also overweight. The pathogenesis is unknown, but insulin resistance presents in 75% of lean and 95% of overweight women. Metformin is commonly utilized to reduce this insulin resistance. However, it has some gastrointestinal side effects, such as nausea, diarrhea, vomiting, and flatulence. That's why another medical option is needed, which can be Inositol. It has no toxic effect, and according to an Australian guideline, Inositol can currently be considered as a complementary therapy in Pcos, with emerging evidence on efficacy highlighting the need for further research. That's why our aim was to examine the potential beneficial effect of Inositols in the treatment of Pcos. Are Inositols efficient and safe in the treatment of Pcos? This was our clinical question. The population was women with Inositol. Intervention is Inositol, comparators, placebo or metformin, and our primary outcome is presence of ovulation and cycle length. The secondary outcomes are BMI, pregnancy rate, carbohydrate metabolism, and clinical and laboratory hyperandrogenism and side effects. Our hypothesis is that Inositols are non-inferior compared to metformin regarding the presence of ovulation and cycle length. The systematic search was conducted at the 20th of October, and at the end of the full-text selection, we found 26 eligible articles. Now let's turn to the results. To have a regular menstrual cycle is the key to women's fertility. That's why our primary outcome is cycle normalization. We found 2 eligible articles comparing Inositol treatment to placebo, suggesting that in the Inositol-treated group, women has almost twice more likely to have a regular menstrual cycle compared to placebo. We also compared to metformin, where we found non-inferiority. In the next few slides, I would like to summarize the results of studies comparing Inositol treatment to placebo. I colored those rows where we found significant results, and the different colors are meant to highlight the quality of evidence. In case of BMI, we found 8 eligible articles, which shows us that Inositols can significantly reduce BMI. Especially Inositol seems to have beneficial effect in weight loss. We found only 4 articles regarding pregnancy rate, where we didn't find any significant difference. Regarding androgen profile, Inositols was proved to have a beneficial effect to reduce the serum level of total and free testosterone and androstenedione. In androstenedione, especially Inositol seems to have a favorable effect. In case of sexual hormone binding globulin, we found that Inositols can significantly increase its levels. We also investigated carbohydrate metabolism, where we found that Inositols can significantly decrease the serum fasting glucose and the area under the insulin curve too. In this slide, I summarized the results of studies comparing Inositol to the gold standard treatment metformin, where we found non-inferiority in almost all of the cases except 2. One of this outcome was sexual hormone binding globulin, where Inositols was proved to have a beneficial effect compared to metformin, and the other outcome was Ferriman-Gilway score, where metformin was proved to have a better effect. The strengths of our study is that we compare not just inositol, not just to placebo, but also to the gold standard treatment metformin, and we examined plenty of outcomes. We also examined different inositol stereoisomers, but we have also limitations, which is the small number of studies with small sample size and too heterogeneous population, the variable follow-up time, and that studies administered different dosages of different inositol stereoisomers. The implication for practice is that inositols are effective therapeutic approach, and they might be considered as a non-inferior treatment in PCOS. The implication for research is that further RCTs are needed to with bigger sample size to assess the effect on pregnancy rate. And also possible additive effect of metformin and inositol co-administration should be examined. With this figure, I would like to present the role of insulin resistance and hyperandrogenism in the pathomechanism of PCOS. According to our meta-analysis, the following factors are influenced by inositol administration. So inositol can reduce BMI, insulin levels, it can increase the sexual hormone binding globulin levels, it can decrease total and free testosterone levels, and we can say that inositol may have a positive effect on ovarian function too. So inositol treatment has beneficial effect on several parameters, and in the most relevant outcome measures, inositol showed non-inferiority to the gold standard treatment metformin. These suggest that inositols are promising alternative treatment in PCOS, especially in patients who have several side effects from metformin. I would like to present my second meta-analysis too, which is about the preventive effect of inositols in gestational diabetes mellitus. Gestational diabetes mellitus is the most common disorder related to pregnancy, and it affects about 7% of pregnancies globally. It can cause several maternal and offspring complications such as macrosomia, jaundice, or gestational hypertension, and in long term, for the mother who suffers from GDM, has 10-fold higher risk for developing type 2 diabetes mellitus and 2-fold higher risk for cardiovascular events. Despite of these facts, there's no medical treatment is generally prescribed for the prevention of GDM. But as I mentioned earlier, inositols are great insulin sensitizers and they have no toxic effect. So that's why our aim to investigate the preventive effect of inositols in the development of GDM. Can inositol treatment prevent the development of GDM in pregnant women? This was our clinical question. Population was pregnant women. Intervention was inositol. Comparators were placebo or no intervention at all. And our primary outcome was the GDM diagnosis by the time of diagnostic oral glucose tolerance test. And the secondary outcomes was need for insulin treatment, results of OGTT, and maternal and fetal complications listed in the slide. Our hypothesis was that inositols can decrease the incidence of GDM compared to placebo or no intervention in high-risk pregnancies. The systematic search was conducted at the 5th of November, and at the end of the full text selection, we found 11 eligible articles. Our primary outcome was GDM, and we found that the incidence of GDM is significantly lower in the inositol-treated group compared to placebo. If GDM develops, the second most important question is the need for insulin. And we found that in the inositol-treated group, the need for insulin treatment was significantly lower too. And we can say this too for preterm births. So inositol treatment could significantly lower the preterm births too. So we can conclude that inositol treatment reduces the risk of GDM compared to placebo or no intervention at all at high-risk pregnancies. And if GDM develops, despite inositol's treatment, it still reduces the need for insulin treatment and preterm births. Overall, we can say that inositols can decrease the incidence of GDM. Currently, we are focusing on the first manuscript, but after we finish it, we are plan to write this manuscript and to publish it in Diabetes Care. Hopefully we can submit our 2 meta-analyses by the end of the summer, and based on our second meta-analysis, we are planned to do also a protocol of a randomized trial. I would like to finish my presentation with a quote from Bill Gates. "We all need people who give us feedback. That's how we improve." And thank you for your kind attention.
Congratulations on your results. In the studies, what kind of inositol were used exactly? Do you have any knowledge about this?
What kind of inositols? Myo-inositol and dechiroinositol, or in combination of these two? Do you mean the dosage? Or
yeah, I mean the dosage, yes.
If they use the combination of myo-inositol and dechiroinositol, they usually use 1,100 milligram for myo-inositol and 27.6 milligram for dechiroinositol.
All right, thank you.
Just regarding to this, I would like to ask that is there any difference between the effect of these two different types of inositols, and is there any evidence on it?
Thank you for your question. Yes, there is a difference between them. An aromatase enzyme is responsible for converting androgens to estrogens. And myo-inositol and dechiroinositol can affect this aromatase in an opposite manner. Myo-inositol enhances this aromatase activity. Meanwhile, dechiroinositol it's an aromatase inhibitor, so it blocks this conversion. So it results that androgen accumulation and the lack of estrogen. So that's why you should avoid to administer dechiroinositol in high dosage and for a long period, because at the beginning of the treatment it can improve insulin resistance, but in long term it will worsen the symptoms of hyperandrogenism.
Would you recommend inositol for pregnant women with familial anamnesis, for example, or with obesity or advanced age, maternal ages, or just with the diagnosis of insulin resistance?
I would definitely recommend it for every pregnant woman who is in high risk, as you mentioned, for example, a positive family history or an advanced maternal age.
Thank you very much.
Thank you for your question.
I just wanted to ask you, how do you define cycle normalization? Is it by the length or the regularity?
Oh, it's a great question. We struggled with this definition a lot because we registered in our primary outcome in postpartum as the presence of ovulation or cycle lengths. But these RCTs provide so variable information about that. For example, some of the studies reported on cycle length, some of the studies reported on luteal phase or luteal ratio, and they didn't provide enough information about the baseline data, just about after treatment data. So that's why we decided to use this mesh cycle regularization, and we put just those RCTs where we had information about the baseline data and after data.
So I would have a question concerning your first topic. In your clinical question, not only the term of effectiveness, but the safety was also included. Why? Is there a higher chance of having any disadvantage or side effect of taking inositol?
Yeah, I put onto my slides the side effects, but we also collected these two. And disadvantage is only just the side effects. Only one RCT reported on side effects from metformin. and we pooled data about the side effects from metformin and side effects from inositols, and at the end of this analysis, we found that in 10% occurs side effects from inositol, and in 60% occurs side effects from metformin.
What were the side effects of inositol?
Mostly gastrointestinal side effects, flatulence.